All right, so today we are going to talk about. So we have two sessions. The first session being the hip joint as well as the knee. So because of our time, I'll try to cruise as fast as I can, and also for everyone to understand the anatomy of the hip joint. Hip joint, basically, it's a joint. It's a synovial joint, a ball and socket joint. So as you can see there, that is your hip joint. It is formed by two articulating surfaces. Is closed by a transverse acetabular ligament. So this transverse acetabular ligament will convert the acetabular notch into an acetabular foramen. The acetabular foramen is very important because it accommodates or facilitates the the the, 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 the transport of the acetabular branch, which supplies the hip joint, which will be coming from the posterior obturator artery. We're going to talk about that when we are talking about the blood supply to the hip joint. Right? Are we together? Are we still together?
Yes, sir, we are
Yes.
together.
All right, amazing. All right, so let's go. So yeah, so I think I managed to say much. So the acetabular labrum is formed by hyaline cartilage. It deepens the concavity of the socket part of the hip joint. And then it's formed by the ilium, 2/5 of the ischium, 2/5 of the ischium, as well as 1/5 of the what or the pubis. Yeah, I think that one you can also take note of it. Right, going deeper. So this is our femur. So we say that the head of the femur is globular, as we can see, and it forms 2/3 of the sphere, 2/3 of the sphere. So which also means that the hip joint is more stable um, than the than the glenohumeral joint, right? Because we understand from upper limb that the glenohumeral joint is deficient inferiorly, made by 1/3 of the sphere, all those things. But the femur, the hip joint, um, the hip joint is what is more stable as compared to the what to the glenohumeral joint, right? So the head of the femur is covered by hyaline cartilage, except a depression that is called a fovea capitis. A fovea capitis. So fovea just means a depression. Capitis just means head. So it means a depression on the head of the what? Of the femur. This is a very important depression because it's going to contain two important structures. One being the ligament of the head of the femur, and inside the ligament of the head of the femur, you're going to have what you call the artery to the head of the femur. We're going to talk about that as we go. So this is the head of the femur, the neck. The neck is quadrangular in space. It is a quadrangular shape, and there is what you call a head to shaft angle. So our shaft is oblique, is not vertical. You need to take note of that. If we are going to draw the shaft, the vertical plane of the hip of the femur, you're going to find out that the femur is not vertical; it is oblique. So you're going to find that the shaft will touch the middle part of the head as well as the middle part of the intercondylar fossa. So it's very important. So we are going to have an ankle that will be between the shaft, that will be between the neck and the shaft. That is called the neck shaft angle. So in children, it's roughly about 160 degrees, and in adults, it's about 125 degrees. Very important. You need to take note of that. And you can have some clinicals or some, let me say clinicals, where there is alteration in the angle of the shaft. Let me just say it. So you're going to find like we have something like coxa vara. Coxa vara just means a decrease in the angle of the shaft, which means the shaft neck angle will be below 125 degrees. So this usually will cause the hip bone, the hip joint to be limited in what? In abduction. In abduction. So you can just get this mnemonic like vara abuda. So if there is coxa vara, there is a limited in abduction. And then the opposite is coxa valgra, which is an increase in the ankle 120 greater than 125. This would be which means the joint would be limited in adduction, right? So I think basically that's the femur. That's part of the femur that we need to understand before we get deeper into the what? Into the joint, right? So like we say that we have these are our acetabula, made by the ischium, made by the ilium, made by the pubic, that depression with the acetabular labrum, with the acetabular notch, converted into the foramen by a transverse acetabular ligament. The foramen facilitates the transport of the acetabular branch of the posterior obturator artery. Yeah. So yeah, that's something to take note of. All right, let's go. Right. So let us now get deep into the joint. So our joint, since it's a synovial ball and socket joint, it's going to be covered by or reinforced by what you call a capsule. A capsule. This is a strong, thick capsule. So medially, it attaches to the margin of the acetabulum, right? Right? And the transverse acetabular ligament, and as well as the adjacent margin of the obturator foramen. So those medially here, medially. So we are saying there, the margin of the acetabulum, the transverse acetabular ligament, as well as the margin of the obturator foramen. That's where there is attachment, the medial attachment of the capsule. And then laterally, very important, you need to take note of laterally. Laterally, anteriorly, so if you're going to find that at the femur, we have the greater trochanter, the lesser trochanter. Anteriorly, between the greater trochanter and the lesser trochanter, we have the intertrochanteric line. Posteriorly, the intertrochanteric crest. Anteriorly, mind this, the capsule, it will attach the intertrochanteric line. So which means anteriorly, the neck is completely capsular. You're getting it, right? It's completely capsular here. But posteriorly, the neck is incompletely capsular, or it's partially covered by the capsule. Because posteriorly, the capsule is going to attach in the proximal one half of the posterior neck. So it is not completely covered posteriorly. It's completely covered anteriorly. I hope you have taken note of that, right? Right. So the greater and the lesser trochanter, they are extracapsular. So it's very important because to understand that the greater and the lesser trochanter are extracapsular, because if you are to study the fractures that occurs at the femur, you're going to have what you call subcapital fractures or intercapsular fractures, right? Which is within the what? The capsule. You're also going to have intertrochanteric fractures between the trochanteric between the greater and the lesser trochanter, and then you're going to have trochanteric capsule, just like here between the origin of the what of the shaft, right here, and where the neck terminates, right? So it's very important to know that the fractures that occur intracapsular, in the intracapsular, they will result in AVN. What is AVN? That is a vascular necrosis of the head of the femur. Intracapsular fractures result in a vascular necrosis of the head of what? Or the femur. Exactly. We're going to talk about later about the joint, the blood supply of the joint later, right? So now, this is the capsule. I hope you have understood. Anteriorly, it's completely capsular. Posteriorly, it's partially intercapsular. Is it? We go. All right. So we now go to the synovial membrane. So as we have said that this hip joint is a synovial ball and socket joint. So which means we need the synovial membrane. And the synovial membrane, it is within the capsule. It is reinforced by the capsule, is within the capsule, right? So it lines the intercapsular portion of the neck of the femur and both the surfaces of the acetabular labrum. So it's going to line the acetabular labrum, the acetabular fossa. What do we say? What did we say is found in the acetabular fossa? A ped of fat, right? And that ped of fat is covered by the synovial membrane, as well as the transverse ligament is also surrounded by the synovial membrane. And then you're also going to find that the head of the femur, okay, um, sorry, the ligament of the head of the femur is also enclosed inside the capsule. Very much important. I think let me see if I can show you another diagram. Um, Another diagram from here. Um, all right. Where is my diagram here? We're talking about the hip joint, right? All right. So this is what I'm talking about, right? So I don't know if you can see clearly, but this is our joint right here, right? So you're going to find this is your this is your synovial lining. So it lines, it attaches to the periphery of the acetabular labrum, and then it surrounds, it covers the the transverse acetabular ligament, as you can see there, as well as the acetabular labrum, acetabular fossa. You can see here, and then the ligament of the head of the femur is enclosed in a synovial sheath. You can see, right? Right. So, like we say that inside this ligament, you're going to find the artery of the ligament of the head of the femur. Right. So, let's go back. So, this is your acetabular foramen, which was converted from a notch by the transverse acetabular ligament. I think we are now good with this, right? So we proceed. We go. All right. Right. So here, we are now going to the ligaments. The ligaments. The ligaments that reinforce the joint. Right. So you're going to discover, as you can see here, that we have a capsule, and this capsule is reinforced by what? By ligaments. We have an intracapsular ligament and extracapsular ligament. Intracapsular ligament just means they are inside the capsule. Extracapsular ligament, they are outside the capsule. And remember, we said the hip joint is more stable as compared to the glenohumeral joint. So it means that the capsule or these ligaments, they completely surround the hip joint and keeping the head of the femur right inside the acetabulum. Is it? Right. So let's start with here. What you see here. So this one that I'm highlighting here, I don't know if you can see clearly, but this is what you call the iliofemoral ligament. The iliofemoral ligament is Y-shaped. You can see here, right? It's Y-shaped. Is one of the most strongest ligament in the body. Take note of that. The iliofemoral ligament is one of the strongest ligament in the body. So the stem of the Y is going to attach to the anterior inferior iliac spine. What muscle attaches there? In the anterior compartment of the thigh. What muscle attaches to the anterior iliac spine? You can write in the chat box. Write in the chat box. Write in the chat box. All right. So this is our iliofemoral ligament. So the iliofemoral ligament, it attaches the intertrochanteric line. You see, this is your intertrochanteric line. It is Y-shaped. Very important. It reinforces the capsule anteriorly, right? And this is very important. Take note of this. Take note of this. Take note of this. It prevents overextension of the hip, of the thigh on the hip joint. I'll repeat this one. It prevents overextension of the thigh on the hip joint. Is it? All right. So we are done with the iliofemoral ligament. Let's rush. What else have I left here? Let me see. The best, we said, at the anterior inferior iliac spine. So another muscle, a muscle that has its origin on that position is the rectus femoris. Remember, a part of the quadricep um, muscles, right? Rectus femoris. It also attaches there, right? So this is your iliofemoral ligament. I'm done. We are now going to the pubofemoral ligament. So from the word pubic, femoral, right? So you already get a glimpse of where it's coming from and where it's going. So it is triangular in shape, as you can see. It is triangular in shape. Can I see it here? No, I can't. Can I see it here? So this is the pubofemoral ligament. You can see it right here. This is your pubofemoral ligament. It is triangular in shape, as you can see. So the base of the pubofemoral ligament, it attaches, or yeah, to the superior ramus of the pubis. This is your pubis. This is your pubis. So it's attached to the superior ramus of the pubis and insert or attached to the intertrochanteric line. Some texts say between the two lips of the iliofemoral ligament. You can find it there. But this one, it cannot clearly see. There are some variations. Yeah, there are some variations. But some texts, indeed, they highlight it. Let me see if this one managed to show. Okay, yeah, you can see it right over there. You can see it, right? So this is the iliofemoral ligament between the two limbs. Here the pubofemoral ligament, the superior pubic ramus, yes, and then attaches the intertrochanteric line. This is a pubofemoral ligament. Very important, very important. You must not forget this one. Triangular in shape, like we have said, and then its function. Basically, it um, it reinforces the capsule inferiorly. So which means that in the hip joint, the hip joint is not deficient inferiorly. You have the pubofemoral ligament there, is it? So the pubofemoral ligament, it's going to limit two things. What is it going to limit? Two things, right? Okay. It's going to limit two things, right? So since it is in the inferior aspect, when we are trying to extend this joint, it will prevent overextension of the joint. Just imagine we're trying to overextend this one going this side, it will pull medially. As well as we are so extension. This I was explaining abduction. So it prevents over abduction of the thigh, over abduction of the thigh. So if it's going this side, right? If the thigh is going this side, it will pull it medially and also prevent overextension. So two things that the pubofemoral ligament does: one, prevents the overextension of the thigh on the hip joint. Two, over abduction of the thigh on the hip joint. Right? I guess that's all on the pubofemoral ligament. Let's go to our last one. That is our ischiofemoral ligament. Our ischiofemoral ligament, from the word itself, ischiofemoral ligament, you already know where it's coming from, right? So it attaches medially. It attaches the body of the ischium. I don't know if you can see here, but yeah, it attaches the body of the ischium, and then it is spirally winds around the joint, attaching to the greater trochanter. This is your greater trochanter. So if an MCQ question comes, the following are structures that attaches to the greater trochanter. You can find muscles like gluteus medius, gluteus minimus, and then pubofemoral ligament, ischiofemoral ligament, all those things. So you already know that the ischiofemoral ligament, it's not a muscle. If they say structures, the ischiofemoral ligament should be there because it attaches the greater trochanter. Are we together? Are we? moving. Is there anyone who is lost who needs some clarification upon what we have already done? Or we continue? I can't see the chat box. So, is it okay? We are moving. All right, amazing. So let's continue. Or let's go, guys. Let's go, guys. All right. So that's our pupil. That's our ischiofemoral ligament, right? Amazing. We are done with this one. Okay. What else? What else? What else? What else? What else? What else? Mhm. Right. So I think I managed to say this. Your ischiofemoral ligament reinforces. Oh, another thing that I left, it also limits extension. So you just have to take it like this. The ischiofemoral ligament, right? It limits extension, as well as the iliofemoral ligament. It also limits extension. But akandoka unique pupil femoral ligament. Kind of extension, convagaita footage, abduction. This one. Cannot limit it limits both. So you're good to go. So let us go to now the intracapsular. The intracapsular. Right. So this one is your ligament teres, the round ligament of the head of the femur. So the round ligament of the head of the femur. Okay, before we go this, let's just go and try to see kuti gray. How does gray? Okay, so you can see here, this is your round ligament of the head of the femur. We have already spoken much about it. Where does it originate? Can say originates. It attaches from there. Remember, we said we have the transverse acetabular ligament. You see, this is the transverse acetabular ligament that conveys the acetabular notch to the acetabular foramina. The transverse acetabular ligament is where that's where the ligament of the head of the femur attaches, and then it goes and attach or inserts whatsoever in the fovea capitis. That's the depression in the head of what? Of the femur. Very important. Accompanying a very important artery that is called an artery to the head of the femur. Where is it coming from? From the posterior branch of the obturator artery. So let me just say, okay. So remember, we have an obturator artery coming from the from the internal iliac artery. The obturator artery runs in the lateral aspect of the pelvis, and then it enters what called the obturator foramina. That is, we know this from pelvis, right? When it enters the obturator foramina, it's going to divide into two. I don't know if you can see here. So this is your acetabular. This is your obturator artery. We are going to have a posterior. This is your posterior branch. This is your anterior branch. So the posterior branch is the one that gives artery of the ligament of the head. And then these two branches will further anastomose and form their own anastomosis there. You can see there, right? Yeah. So the artery of the head of the femur coming from the posterior. We have said this for quite some time. All right. So most of the thing we have said here. Okay, I think I'm very excited to go to the blood supply. I can't wait there. All right, so round ligament, triangular. Yes, it's triangular and flat. It attaches its apex, the fovea capitis, base, the acetabular notch, and the transverse ligament. It is enclosed by a synovial membrane. We have said it transmits the arteries of the head of the femur from the acetabular branch of the medial circumflex and the femoral artery. Okay,